CEP president. If you are CEP member, when you see this picture, August 5th, make sure you vote. And hopefully you vote for me. Thank you in advance. August 5th. This is my email, my website. If you have a chance, welcome to visit and let me know your concerns, ideas, and America and Canada will work together for the same goal to maintain the quality of the lab, to offer the tools for pathologists, and eventually to provide the best possible patient care for the patient. So the objectives for this talk today, we try to understand the morphological spectrum of salivary gland tumor and also the diagnostic pitfalls. As we know, when we recognize the pitfalls, then we will come to solutions. Then we want to introduce the latest biomarkers that we can use to help us when we're dealing with the dilemmas. And then the next part is talking about HPV-associated oropharyngeal squamous cell carcinoma and some of the newer technology to help us to help the patient. So in head neck pathology, two major parts. One is salivary gland tumors. We have major salivary glands, and we have minor salivary glands. That make things a little complicated because each has its own feature and each has its own frequency of tumors, frequency of different malignancies. And also the morphology of even the benign normal glands are different from minor to major salivary glands. The smaller you go, the more mucin you have, because the function, the mucin will help us to lubricate the food when we eat. However, the serous will help to release the enzyme that will digest the food. And look at this is benign salivary gland tissue, and then you have lymphoid. Within the lymphoid, you have salivary gland tissue again, and you have sebaceous differentiation. So the different component of the normal histology, and then the different component will give rise to benign or malignant tumors, make these diagnostic approach and task very complicated. And for the following reasons, numerous types of many tissue, we just mentioned that. And even the same tumor has various growth patterns. And sometimes benign and malignant tumors, they share the overlapping features. If you look at something that is high power, you can easily call a pleomorphic adenoma into malignancy. And immunohistochemistry has some function, some value, however, it's not as valuable as other organs. And the clinical presentation usually is not very specific. Most of the time, you see just patient a bump, a mass, and only when there is a facial pain or facial drop or eye drop, then you can know this is probably a bad tumor because it is involved a nerve already. So with those general information, we're going to go with the cases as we imply in the topic that we are going to use the case as a base. So the first one is a 23-year-old female with a bump, and behind the left ear for over a year, fine needle aspiration was not very helpful, and then resection was performed. So cystic adenoma with a mucinous metaplasia was diagnosed in the initial specimen. And 1 year later, the patient complained tenderness and fullness over mastoid tip. And that's where the stump of the resection. So the patient chose to come to Mayo Clinic, Florida to be seen. And as an institution policy, we require to review the specimens when the patient comes to be seen. And this is a original specimen, and you can see this is a cystic lesion. This is the big cystic lesion. It's a smaller, like a little daughter. And however, if you go high power, the cells look very bland. The cell look very bland, but it's surrounded by the soft tissue. And then higher power, we see the mucocyte. Whenever you see mucocyte, there are two possibilities. One is mucin mucinous metaplasia. The other possibility is mucoepidermal carcinoma. So I want to emphasize that you have to rule out a low-grade mucoepidermal carcinoma. And again, you have a more mucinous differentiation. And here I want to emphasize that the mucinous differentiation does not mean you see mucin in the stroma. That doesn't count. You have to see the mucin within the cytoplasm in order we call it mucocyte. And mucocyte again. And because of clinical presentation, we felt this probably an invasive growth pattern. We thought probably this is a mucoepidermal carcinoma low grade. So we did a FISH memo 2. And so one of the things is not that new. However, memo 2 is very valuable in making the diagnosis of mucoepidermal carcinoma, particularly when it's so bland, low grade. To be confirmed with the memo 2 is a good practice. And 80 to 85% of the mucoepidermal carcinoma are positive for memo 2 rearrangement. So the lesion was resected, and here the FISH we did, and here the resection specimen. You see the lesions here, a little flashy, but then no clear demarcation, no capsule. And this is the frozen section. I happened to be on frozen section that day, and you see a lot of mucin and cystic lesion. With the previous case, we were pretty confident this is mucoepidermal carcinoma, and most areas more epidermoid component, a little bit more solid than the previous specimen a year ago, and higher power we see mucocyte and mucocyte there, here. Very nice mucocyte. However, the margin is positive, right? We emphasize the two edges. One edge is the resection margin. You don't want to leave the cancer behind. And the other margin is the edge is the tumor interaction with the benign original tissue, and to see whether this is invasive or just pushing or respecting the border that help us to make a diagnosis, benign versus malignant. However, the margin is positive, so I called my surgeon. We've been working together a lot, and I said, "Why do you stop?" He said, because the tumor is touching the nerve, facial nerve, and the patient didn't want to sacrifice the facial nerve. So as a result, patient had to go to radiation therapy. So this is the lesson that the application of memo 2, a very simple FISH test, will help us to prevent mistakes like that. And as we know, mucoepidermal carcinoma is a low-grade lesion. However, kind of unpredictable. Sometimes even low-grade mucoepidermal carcinoma can be seen in lymph node as a metastatic process. So we need to be careful when you see mucocytes and cystic lesion. And second case is 68-year-old male with a left-parotid mass, and finding the aspiration was not conclusive, so frozen section was performed. And here I want to use this opportunity to see the digital sign art we have. And so basically this is a scanned case, and we really don't have to stay in the office in order to sign out cases, because I have a complete setup at home. If from day to day, I'm staying at home to do all the work the same. You dictate and our secretary type out, is all screened here. And this is a very cystic area. So here, some reactive change, some hemosiderin. It's a very cystic lesion here, very cystic. And some area make me think about oncocyte here, a mucocyte, right? And more area here. So very nice mucocytes here, and cystic mucocyte. So clearly you have to think about mucoepidermal carcinoma, right? However, you have to go low power. Look at the low power. I always tell our resident that fellows at low power diagnosis, high power pathologists, because particularly important in salivary gland lesions, when you encounter the growth pattern or even the capsule, extremely important. But you see this mucocyte. And so at that time, during the frozen section, and some pathologist reached the possibility of a mucoepidermal carcinoma. But however, look at this area. this is pretty typical for what? Pleomorphic, and with the fine needle aspiration history, and then you have to entertain the possibility that the mucosa is a part of the metaplastic process and is not cancer. And so in order to serve the patient who is going through the surgery, and we told the surgeon said, well, this is a low-grade lesion, probably is pleomorphic with a metaplastic process, and we're going to do a FISH. And the memo 2 was performed. So look at the well-demarcated urine the capsule there, and the FISH was negative for memo 2, and you have seen lymphoid tissue there. So this is the example that the FISH was useful, and if you use well, you can help us there to make sure the diagnosis is correct and patient was treated well, accurately. So that's the case with digital demonstration, and this is a final diagnosis of pleomorphic adenoma with features of fine needle aspiration effect and associated mucinous and the squamous metaplasia, and the FISH is negative. So that's another example that the FISH memo 2 is used to help us. The next case is small nodule in the epiglottic area in a 50-year-old female patient. Biopsy was performed. As we know, epiglottic area, if we have any malignancy, when the resection will lead to dramatic negative quality of life impact, because the patient will not be able to swallow well. The patient will not speak well. I'm not sure you have heard patient with the fake voice. It's pretty it's a terrible thing to have unless we have to do it. That's why I want to be careful. The small biopsy demonstrate the tumor here with Swiss cheese look to it, and clearly we thought about adenocarcinoma. Look at the mucoepidome, the epidermal. The adenocystic. This is cystic, right? Adenoid means the gland is open into the stroma here, and very nice demonstration. And occasionally you see a true gland. That's a part of the spectrum. And we did a c-kit, and the epithelium is positive, and it's very typical for adenomyosis carcinoma. However, it's not pathognomonic. The other lesion can present c-kit similar stain pattern. And P63 nuclear stain, see the myepithelial area. The epithelial is negative. So very nice complementary staining pattern with c-kit. And the patient was not very confident to go through big procedures, so the patient wanted us to do a FISH to make sure that the lesion is a malignancy, adenomyosis carcinoma. As we know, it's a very bad lesion, disease to have 90% of the patient probably will die of this disease in 10 years. If it's low grade, if it's high grade, it's going to be even worse. If it's dedifferentiated, probably going to be 10, the patient will die within 2 years. Mayo Clinic and MD Anderson did quite a bit of work as part of the evidence-based. So the grading of the adenomyosis carcinoma is based upon how much solid area the tumor has. If it's 30% or more, it's grade 3. If it's pure tubular, it's grade 1. If you have a combination of tubular, cribriform, and a little bit solid, is grade 2. The reason I mentioned comment on that, the salivary gland tumor grading is getting more and more important because our colleagues request that. In older days, even 5 years ago, we didn't care too much because they didn't need that information to treat this patient differently. Currently, if it's a low grade, they probably watch, and if it's intermediate, they will consider using releasing therapy. We just mentioned releasing therapy is not a good thing to have unless you have to go through, and that's why the grading is important. The final diagnosis, adenomyosis carcinoma, resection confirmed our biopsy diagnosis. And this one is again the FISH technology help us and to confirm before the major procedure was offered. The next case, 56-year-old woman with a lump behind the ear, finding the aspiration was not conclusive. And the reason we chose this case is that the FNA was not very helpful. If they are very accurately classified, probably will be a little easier, but not every time. As we know, cytology is a screening technology, sometimes is not extremely helpful. Now, this is a lesion there. And here the low power, the macroscopic picture shows demarcation and maybe even encapsulated. And here, the low power see the very thin capsule. So this thin capsule really means either it's low grade or it's benign. We talk about that. And very important to see the demarcation, but not necessarily 100% is benign. And higher power, these cells look like a cynic cell. And that's an interesting observation. Actually, most of such cases would sign out as a cynic cell carcinoma before this entity was officially coined. And I'm sure you know what I'm getting at. And then we do immunostain, CK7 positive, hemoglobin positive, S100 positive, and this very unique gene fusion, ETV6 and NTRK3 gene fusion by FISH. And NTRK here, I want to comment on NTRK because, as we know, NTRK is a good target, and we have very effective chemotherapy, individual target treatment, and the effective of this NTRK inhibitor is very high, 70% above. But the issue with NTRK mutation is only 2% of all the tumors carry NTRK mutation. So the dilemma is, as a public health, are we going to screen every tumor to find the NTRK? If NTRK is positive there, we have a tool, but only 2%. Now, that was a problem, but not anymore, because we're talking about new technology, right? The new novel molecular pathology. And big companies like Caris, Tempus Foundation, all this big panel, the sequence of the whole genome, and of course include the NTRK, and which offer the target for possible inhibitor to be used. And as we know, the FISH is not that difficult. However, not every lab will be able to do it. It takes a longer time, more expertise. And if we can use immunostain to translate the genetic mutation information, that'd be ideal, right? And this is hemoglobin, immunostain, cytoplasmic stain. However, B is the pan-Trk nuclear strong nuclear expression. That is a substitute for FISH to be stained. So the final diagnosis of this case is a memory analog secretory carcinoma. It was called MASC. However, the recent WHO classification, some pathologists believe it's a long name and it's hard to pronounce. They just cut it the memory analog part and called it secretory carcinoma. And this is what we are using now. And Dr. Skalova is the primary pathologist who described this entity the first time in 2010, published on American Journal of Surgical Pathology. And she noticed this group of the tumor looked like a secretory carcinoma of the breast. And she did the FISH to identify the NTRK ETV6. It showed identical translocation. That's why she called memory analog secretory carcinoma. And that's her. And during the last USCP meeting, we had a nice picture, and very smart, of course, very nice lady. And as we comment on the Laxo is a company now is merged, I think, with Inalili. That's what one of the major product is, to target the NTRK, and this particular medication will function like that. And 76% of the NTRK mutation tumor will respond. Overall response rate is a kind of really magic target. And salivary gland, and mainly in the secretory carcinoma, is part of the salivary gland that has the NTRK mutation. And so very excited, right? The pharmaceutical company were happy to find this potential application. However, the mostly secret carcinoma is a low grade. If it's a low grade tumor, as we know, resection usually is a cure. So it really depends on it's high grade, low grade, recurrent or not, and whether this is a more aggressive lesion that will decide whether we need to do the NTRK inhibitor. So the temperature is a little calmed down because you don't want to see any NTRK translocations identified. So every patient will receive the targeted therapy. So it depends upon the clinical presentation, the grading, and the staging. So secretory carcinoma may look like a single cell carcinoma, or even mucoepidermal carcinoma. Actually, if you go back to the literature, most of the papers were published based upon retrieving the cases was assigned out a single cell carcinoma or mucoepidermal carcinoma or adenocarcinoma in OS, and then did the FISH, and they found, oh, good chunk of them is secretory carcinoma actually. So that's how the development of the new entity was introduced. And most of the patients with a low grade, as we just mentioned, is about some report high grade. For this high grade secretory carcinoma, I feel the NTRK inhibitor probably will offer some valuable treatment for this patient. And currently, the clinical trial is still undergoing and target on the specific molecular target. And so we have to understand what is the clinical significance and on top of the genetic mutation. And this is the nice summary of the very common cellular gland carcinomas, their genetic mutation. And some of them is a single mutation. And the issue for this, you have it's a big panel, right? It's a big panel. You don't want to do many probes, and you have tissue problem, you have cost of time, and other things, right? And then, not too long ago, I visited University of Iowa. I had a nice conversation with Dr. Deqing Ma, who is the director of the molecular lab and very smart lady. She designed a panel including all those probes into NGS panel. It's a very, very nice. I'm very happy and excited for their development. They did a lot of cases already, and basically, and she invited me to be a collaborator. I'm happy to do more work with them. And basically, this panel, including all 14 genes, and I'm sure you know that all the genetic sequence was stored in CBI and is open to public, and we can get them and design the probes based upon the primers, right? Based upon the sequence 3, 5, and then we do amplification, and then we do sequence. So that's how the principle of this panel is based upon. Now here, so the anchored multiplex PCR is a very unique, it's very useful for this kind of a scenario. And mRNA, you reverse RT, and then you do amplification, and then you do sequence. And here, and you can see MYB mutation and MMO2. And once the sequence was finished, and you see the software to match, to compare the normal, the benign normal sequence, and then they will identify where the specific mutation is. Very valuable. So here the list to compare the three, technologies to identify the mutations. The FISH I use it several times as a kind of classic, or older, relatively older technology. It's still valuable. You just have to be careful not to. You need to evaluate the morphology first with a very short differential diagnosis. You don't want to run 8, 9 FISH, too expensive, too much time, not very practical. So if you have a good understanding about morphology, a very short differential diagnosis is still very valuable. And RT-PCR is valuable, but you cannot do the multiplex amplification. So the best way is the anchored multiplex PCR, and because you're followed by the sequence. And so this is a very nice application. You mean on cytology, if you see something there very suspicious, as we know, cytology again is a screening technology. Sometimes they don't have the structure, the growth pattern of the tissue or the lesion, and you can do a FISH and you carve them out and you do this. We just mentioned the NGS panel, and it's being validated. Is a very useful technology. This is a brand new. I'm very excited. So we're going to summarize the first part is we have to use integrated approach. We want to integrate the morphology and history of finding the aspiration. We want to make sure it's not metaplastic or infarction secondary to finding the aspiration, and the potential pitfall should be watched. And at this time, the novel molecular test is going to be very valuable. And again, whenever we make a diagnosis, we have to think be clinical significant. So this is first part. Second part, as we know in head neck pathology, one is a cerebral gland tumor. The second part is a squamous carcinoma. And you have a smoke and drinking induced squamous carcinoma. However, currently the HPV associate is so common. I'm sure you see that a lot in Canada as well. And within this part, we are going to introduce three areas. One is HPV associated oropharyngeal squamous carcinoma. Second part is HPV associated multi-phenotypic sinonasal carcinoma. The third part is HPV associated papillomatosis. The reason we include these three has to do with the different types of HPV. And epidemiology of HPV in America, 15 million men and women. That's a lot of people, 15 million infected with oral HPV, and those are oncogenic type, means high risk type. As we know, low risk don't create the pathogenicity to be cancer, but the induce papilloma. And the number has surpassed cervical cancer already. As we know, cervical cancer, because of the pap smear, because of cytology, and we did, collectively we did great, reduced millions of, save millions of lives for female patients. And for HPV-induced head neck tumor, most of them present with metastatic disease already. But 80% young patient, generally speaking, generally is man, much more man than woman, and probably 3-to-1 ratio. Young adult or adult middle-aged man with cystic neck lesion is very typical. But this kind of tumor has a better prognosis, and many clinical trials have proven that the radiation dose can be reduced and still maintain a similar treatment effect. So this is the map. You see, it's all over the place. It's all over the place. And this is per $100,000 per 100,000 people, 1.7. See how many dark blue. Pretty impressive map. And some of them that no data yet because probably very poor, no resource to do study like that. And this data coming from WHO. And we just mentioned that 15 million, and this number came from CDC, and it's not somebody who made up. The CDC has a very reliable, relatively reliable data to share. And as we know, the smoking was not allowed anymore, was prohibited in 1970s, 80s. As a result, the head neck pathology, head neck squamous carcinoma has been decreased, which is great. However, it's not true. However, the true, look at this, the truth is the blue, HPV positive or the true incidence is going up. Why? Exactly because it's PV infection. 225% increase, and that's a lot, and we see a lot of them here. So now we go to a real case, 45-year-old male, and again, middle-aged male, with a left neck cystic lesion. Biopsy was performed. And look at this. This look like this reminds you like a tonsil, right? Kind of normal tonsil morphology. This is very typical, and sometimes, most of the time, the neck lymph node is cystic, and you do biopsy, and the cytology can be tough, right? Because in a lot of necrosis and some squamous tibia, it's hard to tell, but it's not high-grade tumor, and that's where it makes it difficult. If a high-grade tumor, we are all very confident to call malignancy. And this look like in situ even, right? But this so-called in situ pattern is not truly in situ because you see them in lymph node already, and this can't be in situ anymore, right? So that's why CEP recommendation, one of them is don't call HPV-induced squamous cell carcinoma in situ, because even it looks like in situ, actually the tumor cells has penetrated the very loose space membrane there, went to neck lymph node already. So the left tonsillectomy was performed and similar histology identified. And one of the things, this is P16, as we know, CEP organized expert and put out the guideline and published 2018, and that's 5 years ago. The guideline is 70% above of the P16 positivity, both nuclear and the cytoplasma stain will be considered as positive stain. And remember, only oral pharyngeal carcinoma has this prognostic value. And we have done a study. I was one of the early authors to promote the idea to look at whether buccal mucosa P16, what does it mean? And what we found is a portion of the buccal squamous mucosa squamous carcinoma is positive for P16, but they do not carry the similar prognostic value as oral pharyngeal carcinoma. So very often we receive a request to do P16 HPV virus, DNA or RNA in situ hybridization, but it's not oral pharyngeal carcinoma. And we will explain to oncologists even you do it does not offer any additional information. So RNA in situ hybridization, this is a very successful company. They introduced this idea probably about 10 years ago. Very smart scientists. What they have done is, as we know, usually test when you increase sensitivity, you decrease the specificity. But they use a very novel technology to amplify the signal and yet very specific. So both specificity and sensitivity very high. And Mayo Clinic, Hopkins, almost every major institution are using this technology we call RNA scope. I happen to know the investigator of this company, and a very nice technology. Now we have different types. We have different variants, morphological variants of HPV-induced squamous cell carcinoma. In older days, we call basaloid subtype, basaloid squamous cell carcinoma. At that time, basaloid indicate is high-grade tumor. However, this morphology is still there. However, if it's HPV associated, it's not aggressive, it's not poor prognosis of cancer, it follows HPV. So that's why the HPV is so important now. HPV is so important because the prognostic and clinical behavior. Now this one is non-characterizing, and when our awareness, our knowledge and interpretation of this tumor has been advancing as well, because we see more and more. When this HPV was first described, and we thought it was only non-characterizing type, actually is not true. Actually, sometimes we see keratinized tumor as well, squamous, and due to P16 infection. Now this is a lymphoepithelial type. When you see that in America and Canada, we don't see a lot of lymphoepithelial type induced by EBV, because nasopharyngeal carcinoma induced by EBV was mainly seen in Asia, Hong Kong, Singapore, part of China, but not in America. I only see a couple of cases, probably those patients travel history or whatever reason. But in America, we see HPV-induced lymphoepithelial type. And make sure this is not a lymphoma. You don't want to see this. This is very syncytial. The syncytial appearance make think about carcinoma. And sometimes you see a glandular differentiation. Here, very clear is a squamous differentiation, but it's glandular. The reason I bother to do all this morphological variant is, if you don't know the morphological variant, you will not make the right diagnosis, right? And so sometimes you see ciliated. And generally speaking, when you see a cilia, you think it's benign, right? Because cilia is part of normal architecture, but not necessarily true in this situation. You see ciliate adenosquamous carcinoma type. And this is a bad, look at this cell. I mean, I'm sure you will not call benign. And this is so pleomorphic and giant cell. And this type is also induced by HPV, but this type of tumor is reported to be more aggressive than conventional HPV-associated squamous cell carcinoma. And I have seen several cases. It does exist. And we mentioned the 2018 archives published the guideline. And as we know, College of American Pathologists, one of the major responsibilities is to help organize experts to be responsible for guidelines, and when new technology, new biomarker emerge. And this is one of the things we have done. And I'm sure these efforts will benefit all the pathologists and even the patient all over the world. And to my knowledge, there are probably 300 pathologists in Canada that are also part of the CEP members. And so we all benefit from the synoptic report, the guidelines, and the lab qualities. And for advocacy, mainly benefit American pathologists, because Canada has their own political system. Now, here you see some maturation. Here's a little bit keratin and reverse polarity, and they help with the diagnosis. And papillary receptor type is very interesting. Why I say interesting? Because sometimes it's a papillary configuration. You don't see invasion, and you would think this is high-grade dysplasia or squamous cell carcinoma in situ, but actually it's invasive squamous cell carcinoma, but with a papillary configuration. And this type of tumor does have a better prognosis compared to conventional squamous cell carcinoma. Now, the next one I want to spend some time is, and we know the morphology, we know how to detect the substitute P16 and the guideline and the HPV DNA, RNA, high risk, low risk, but circulating plasma / serum HPV DNA is getting very popular. I'm very happy and proud that we started, we are one of the labs started 5 years ago. We created some very valuable data. We documented that the HPV DNA copy numbers in the blood, circulating plasma and serum, or serum, was reduced to 0 when the patient was receiving definitive treatment. And so we proposed that this technology can be used to screen and monitor the treatment efficacy and monitor the early recurrence. And now more and more paper was published, and even commercial labs came to be existing and doing commercial work. And some of the clinical trial actually is based upon these circulating plasma / serum DNA copy number.
Oh,
So this is a very nice plot, and the DNA when going up back again, that means what means is the patient recur, and the different scenario means patient recur. So we produce a very similar curve when the patient receives definitive treatment, the DNA going down, when coming back and going back. So this is a very nice paper published 2020, and a lot of more papers actually were published after that. So that's a liquid biopsy, and they're very valuable in our daily practice to monitor recurrence and treatment efficacy. Although HPV-induced squamous cell carcinoma tend to have a little bit better prognosis than the smoke and drinking induced squamous cell carcinoma. I do see some patients die of that disease. It's still killing patient, and we need to pay attention. And the circulating liquid biopsy is a powerful new technology. So the next entity is HPV-associated multiphenotypic sinonasal carcinoma. And in the past, again, our knowledge of understanding about this lesion take time. And the earlier one we called adenomyosis carcinoma, because it looked like adenomyosis carcinoma. But now we know it's HPV induced, particularly the type 33. And we know HPV, there are more than 200 HPV types, right? And 33 for the HPV induced oropharyngeal carcinoma, most of them is HPV 16, 18, right? And now 33 is responsible for multiphenotypic carcinoma. And again, this is a better prognosis, and we comment on the adenomyosis carcinoma. Most of them will kill the patient in 10 years. However, if it's HPV-induced lesion, although it looks like adenomyosis carcinoma, but it's a different entity, and that's why it's important that we recognize them. And if you look at this, it really looks like adenomyosis carcinoma, right? Solid, right? If you look at this, if it is truly adenomyosis carcinoma, this is high grade, and patient will die around 2 years, but not in this case because it's HPV induced. And sometimes you see clearing change, myopithelial change, and again, c-KIT, we showed a c-KIT immunostain before, and that's why it was called adenomyosis carcinoma. And later on, we realized that this is not the same. It's not the same. So here is again the RNA in situ hybridization. So the HPV 33. It's very important to understand the different types of HPV induce different lesions, different problems. Another important thing is the epithelium is part of the process, and the epithelium is dysplastic. And this is invasive cancer, right? Look like adenomyosis carcinoma. The pure adenomyosis carcinoma coming from minor cellular gland, and they don't have the epithelium dysplasia association. And again, myopithelial marker like P40 nuclear stain demonstrate very similar staining pattern like adenomyosis carcinoma. So when you see this, you want to make sure HPV is performed. Myopithelial marker is similar. They staining the basal cell, myopithelial cell layer. And the next one, we want to talk about laryngeal papillomatosis. And this type of tumor induced by HPV 6 and 11. Generally speaking, they don't produce cancer pathway, however, they recur. I'm sure you have seen that, particularly in younger patients. When I was at the University of Cincinnati, we have a very strong children's hospital there. We see quite a few. It's very disturbing because you cannot get rid of the HPV. You resection, they come back. You do resection, they come back, and occasionally this local aggressiveness can do a lot of harm for the patient. They created fibrosis, stenosis, a lot of problem. And that's one of the reasons actually when you see papillomatosis, the clinician asks us to do the HPV typing. So it's 6 and 11. Those are the ones are responsible for the papillomatosis. And how do the children get the receive this virus during the delivery in the birth? And um, so this is the summary of the second part, the molecular test obtaining more and more attention, I'm sure you know, and it become integrated part of daily practice and treatment. And there are a couple of trains. The larger company, larger panel company, I mentioned a few, Foundation, Tempus, Carries, they have a lot of resource, money, and the technology and the expertise. The panel is getting bigger and bigger, include a lot of information. And at the same time, many institutions have more tailored panels. And at the Mayo, we, for example, recently we just published and make it available the endometrial carcinoma panel. And because we know the classification, molecular classification of endometrial carcinoma, and based upon histology is not enough. And University of Iowa, I just spent quite a bit of time to introduce that the NGS panel, including all the cell organ rearrangement and translocation on point mutation on and on. So those are things in my mind will come to our attention, and the validation part and the bioinformatics part are very important, because we cannot just use a test for patient without validation, because the quality of the patient care is the paramount that our pathology trying to achieve. Thank you so much for your attention, and we have 9 minutes left, and be happy to interact if any questions, comment, and thank you, Dr. Gao.
Yeah, thank you, Dr. Zhai, for the nice presentation. Anybody has any questions to Dr. Zhai? We have local experts in this area as well, and maybe they have some comments, questions to Dr. Zhai, please.
So do you guys do fish? And it depends. Some pathologists are very confident you don't need fish, and some pathologists need more confirmation. How about digital, Dr. Gao? Are you guys doing digital yet?
We're working on it. I say different levels.
Yeah. Because in America, let me stop share. In America, it's about 20% of the labs are using digital. So it's quite a spectrum. Some smaller labs, they don't have the resource, the support, and the expertise to do that yet.
Yeah, in Canada, there is big variations from province to province, from labs to labs, and BC is a bigger province. There's variations in practice in different labs as well.
Yeah. I think it's a kind of part of the normal spectrum, and it will take a while for more labs to take on, because again, it takes a lot of resource.
Anybody has any questions or comments to Dr. Zhai? So please make sure that you support Dr. Zhai's candidacy for this CEP president. This is a pretty important position. He's dedicated his time for almost a decade. He's serving the committees of various committees. Yeah.
Thank you very much. Yeah, I've been involving with the CEP for 20-some years, involving almost all perspective education. I wrote 2 books for CEP. One is the quality, the other one is the grossing. The quality one, I think Dr. Gao has a copy, right?
Yeah, I have the grossing as well.
Yeah. This one is relatively new, right? This one we got a couple of years ago. The quality probably is time to update. And inspection, I went to many countries to do inspection, and America, of course, domestic, and offer a lot of constructive ideas, because we are living in new technology. The old methods need to be updated, and membership and the state society.
There's a question in the chat saying
I'm
that
sorry.
for digital sign out, was there an intensive validation before you started using the system?
Yes, we have to validate. Actually, in theory, it's pretty easy, right? However, in reality, is the resource. Thank you for the question. In reality, the resource, you have to buy all the equipment, you have to hire more people, gain validation, and we take steps. The validation start from, for example, small biopsy first, right? And you read how many cases using the digital, you read the real slices, you compare, right? Because that's yeah, it takes a long time. That's why actually only 20% of the labs in America are using this. Actually, it's been a while, right? It's not, the idea, the equipment was available for a while. Everybody said, well, next 5 years, nobody will use the scope. But I don't think they're fast. It's coming along slowly. Again, depends upon each lab, and because again, it requires time. Validation is part of the efforts. You have to slow down, right? You have to slow down. You have to spend extra time to do the validation. And yeah, I agree. Digital, yes. Yes, that's the answer, I think. Yeah, we do a lot of.
Okay, please ask Jim about the role of cytology combined with molecular testing in diagnosis of salivary gland tumors. So the question is about cytology combined with molecular testing.
Yeah, so that's one. Thank you. That's very exciting. Dr. Ma, Dr. Ma is actually, we went to the same medical school, so I'm so proud. She's doing a lot of great work. And they present their findings at USCP recently, USCP annual meeting platform, very well received. And the idea is, as I showed on the slide, and you find some cells of interest, right? And then you circle on the back, and then use the special gel to take all the cells out of the slice, and then you extract DNA, RNA, right, and total nucleic acid together, and then you use the NGS panel. And actually, I think it's wonderful because you can do all the mutations, all the rearrangement together at the same time, right? Although if you do fish, first of all, for fish is difficult on cytology, right? You don't see the architecture, and also you need the multiple slices. Right, one time, one fish, one slide can be done one fish, one probe, right? If you have 8 probes, you have 8 slices, and on cytology it's not practical. So this is, I think, it's a very a nice new technology. They validated already, and they are starting to do as a routine, And she invited me to do more study together, and hopefully we have some collaboration going on, but they have done a very nice job already. Thank you. That's a good pick, and it solved a lot of practical problems. And because I see a lot of salivary gland tumor on the cytology, sometimes hard, but they don't have the architecture, right? You cannot evaluate whether it's invasive or not. A lot of things you cannot see on the cytology specimen. Thank you for the question.
Other questions, comments? We have another minute left. Maybe you can still talk about this AI application in pathology. Where do you see that going?
Thank you. AI, I'm very interested. I'm doing a project. I'm trying to create a algorithm with the Mayo Clinic and Alphoria. I'm sure you heard this big company, Alphoria. And the idea is, because I'm being interested in GU as well, and I wrote a book with Dr. Jero on bladder cancer. What happened is, the reason actually is interesting historically, the reason I was ready to write the book is I want to learn so much, and it's so subjective. And between pathologists and the reactive versus urothelial carcinoma in situ dysplasia is very subjective, and it's same problem for me too. So I learned, took a few years, and I got much better, no question, after the book. However, it's still subjective. So the current practice is we try to use the algorithm to create a new one. Now, it's a similar thing with, I think it's similar with the digital, because you cannot do AI without digital, right? And even the same thing, what I mean is same thing, it's coming along, but take longer than we expected, because we have so many entities. And even this one, you would think is one of the relatively straightforward urothelial carcinoma in situ versus reactive. It takes so long, and I have to look so many slices, work with IT. It looks promising, but it took so long, and again, it will take longer than we think and than we hoped, but it is coming along. That's no question, and because so many companies invest time, money, resources, so many pathologists. If you go to, I'm sure many of them went to US CEP meeting. So many abstracts, so many projects about AI. And the more work you do, the more breakthrough will have, and the technology will be more mature. But again, it will take probably longer than we hoped. It's coming, definitely coming on.
Excellent, thank you. So thank you, Dr. Zhai, for the very nice talk. And thank you everybody for attending this talk. Please vote for Dr. Zhai. And okay, thank you. We'll see you. Oh, thank you. Okay.
Thank you. Have a good afternoon. Thank you for having me, Dr. Gao. Thank you.